Hello, my dear. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today, I wanted to speak about COVID-19 and pregnancy. So, what we wanted to discuss today, the virus, how it is transmitted, its clinical presentation, how to diagnose using investigations, prevention, what is the recommendation during pregnancy, labor, and postpartum period, and lastly, the treatment. Let's start our journey. This coronavirus, COVID-19, first detected in Wuhan City in China in late December, and which has now been detected in more than 150 countries internationally. Look to this table, please. This is the name of the virus, and this is the disease. The name of the virus is called SARS-CoV-2, while the disease is called coronavirus disease 2019, and WHO did abbreviation to the name to be COVID-19, to be easy in its use. SARS, we know another SARS-CoV, which occurs in 2003 in outbreaks. Okay, so this is another coronavirus, the new one, our title today. The virus belongs to a large family of RNA viruses affecting animals like cattle, like camel, cats, and bats, and they also affect humans, and they can be transmitted from animal to human and from human to human. The coronavirus groups include the common cold, the SARS-CoV, and the SARS-CoV-2, and the MERS. As you see here in this picture, SARS outbreak in 2003, MERS outbreak in 2012, with many mortality rates. COVID-19 started in 2019. What about the outbreaks? Started late in January 2020 as an outbreak, then became pandemic, as mentioned by WHO on 11 March 2020. Today, in early morning, I recorded the number of total cases exceeding 2 million. Total this is exceeding 146,000, and total recovered cases exceeding 547,000. So this pandemic is very important, and this virus is very important and dangerous one. Transmission from person to person through droplet infection within 6 feet, or by contact with infected objects or surfaces, then touching the eyes, mouth, or nose, then the virus transmitted. Clinical presentation include fever, cough, shortness of breath, fatigue, and myalgia. In severe cases, may be complicated by pneumonia or acute respiratory syndrome, or acute kidney injury, liver dysfunction, heart attack and arrhythmia, pulmonary embolism, and even death. Clinical presentation range between mild symptoms to moderate up to severe illness, which constitutes 16%. As you see here, the lung affection with viral pneumonia in both pictures, with striation, peripheral consolidation, characteristic of viral pneumonia, who are at higher risk of severe illness. People with older age and with chronic lung disease and asthma, serious heart conditions, immune-compromised patients, severe obesity, 40 body mass index or more, people with diabetes or chronic kidney disease or with chronic liver disease. Three important questions. Is pregnant woman at high risk? What about the pregnancy outcome? And is there any vertical transmission from mother to fetus? Let us start with the first question. Is pregnant woman at high risk? Actually, to date, there is no scientific evidence about the increased susceptibility of pregnant women to COVID-19. On the other side, due to physiological changes, maybe the pregnant lady at risk if has a lower respiratory tract infection. So, the condition may be hazardous if lower respiratory tract infection occurred with pregnancy. And the patient usually need hospital admission and intensive care admission. In a case series in New York, for 43 women pregnant and positive COVID-19 showed a similar pattern of disease severity like non-pregnant adults. And as you see from numbers, 86% were mild, 9% were severe, and 5% only were critical, similar to non-pregnant adults. In other types of coronavirus infection like SARS and MERS, the risk to pregnant women appear to increase, in particular during last trimester of pregnancy, and we should take care about this point. Last trimester of the pregnancy is the most dangerous one and liable more for complications. Given that pregnancy is known to be hypercoagulable state, this is very important, and also it was found from different reports that COVID-19 associated with hypercoagulable state, so increase the risk of thromboembolism during pregnancy. Add to all of this that the pregnant lady was COVID positive, you ask her to be isolated with limited mobility, so it is also for risky for thromboembolism. What about the pregnancy outcome and of the reported cases? This is the second question. Spontaneous and iatrogenic preterm labor are the most commonly reported adverse pregnancy outcome, and also premature rupture of membrane. But fortunately, maternal infection with COVID-19 wasn't associated with teratogenicity or miscarriage or stillbirth. So, in 60 cases of pregnant women confirmed with COVID positive, the pregnancy outcome of the reported cases in China has been largely good. Adverse pregnancy outcomes are most likely related to severity of maternal respiratory compromise. So, if the mother is affected with severe or critical respiratory problems, this will affect the pregnancy outcome. Is there any evidence of vertical transmission? This is the third question. Actually, many reports showed that there is no evidence of vertical transmission from mother to the fetus in COVID-19. But recently, in a case report, it was found that there is vertical transmission, so we shifted from being no vertical transmission to say probable risk of vertical transmission, even if it is low. What is the investigation needed? We need to take nasopharyngeal or oropharyngeal swab, or from the saliva, or from the sputum, or endotracheal aspirate, or bronchoalveolar lavage, or from urine or stool, then do PCR, real-time PCR, and we should do 2 tests 24 hours apart from each other if the first result was negative. So we should do 2 tests of real-time PCR. Also, serological tests can be done, but antibody to be formed, it needs time, not less than 2 weeks. We know that we have IgM and IgG. IgM develop early. So if I wanted to diagnose a recent case, maybe not wise to do serological test. PCR is better, but serological test is important to know who is immunized, who have antibody in his serum. So it may be beneficial, especially for healthcare provider. CBC show lymphocytopenia, thrombocytopenia, leukopenia. Also very important to know the neutrophil lymphocyte ratio, and the cutoff of 3.2 or more is alarming for severe illness. C-reactive protein may be increased, elevated liver enzymes, and the creatine phosphokinase, which increase with cardiomyopathy or heart attack. Elevated inflammatory markers like D-dimer and ferritin is very important. What about CT? CT is very important in diagnosing COVID-19 because it has characteristic viral pneumonia signs. But it carries some little risk to the fetus because the pregnant lady is contraindicated to do CT, but here the benefit much weight the others. But the minimal risk can be reduced by taking barrier and all precautions to minimize the amount of radiation exposure to the pregnancy. CT findings include, as you see in the picture, consolidation, round consolidation. Look to this picture, please. Round consolidation at the periphery of the lung loops, lung consolidation. Striation, linear striations, or linear opacities. Crazy paving pattern. This is a crazy paving pattern. Okay. Bilateral lung affection. And by the way, in early patients, 28% are affected bilaterally. In intermediate patients, 76% affected. And in late cases, 88% affected. Lastly, this sign is called reverse halo sign. So we have peripheral round consolidation, linear opacities, and crazy paving pattern, as in this picture, amalgamated consolidation with linear opacities and striations, and lastly reverse halo sign. To continue our investigation, we should screen for other respiratory infection, other viruses like influenza, syncytial virus, like SARS-CoV, like also bacterial pneumonia, chlamydia, and mycoplasma pneumonia. Also, we can take blood culture for bacteria, for sepsis or septicemia and the pneumonia. How to prevent in pregnant lady like any adults? Steps to protect yourself and steps to protect others. Steps to protect yourself: clean your hands, avoid touching mouth, nose, and eyes, avoid overcrowded area, avoid public transport, avoid close contact with sick people and unnecessary travel. Steps to protect others: wearing mask, stay home, don't share dishes, drinking glass, eating utensils, towels, or bedding with other people, avoid public area, cover mouth and nose while sneezing or coughing. What is the recommendation during pregnancy, labor, and period? Pregnant women should take the same preventive action to avoid infection recommended for all adults, as we said before. Pregnant patients with respiratory symptoms should be asked to wear surgical mask immediately. upon presentation to healthcare facility. Women above 28 weeks in the last trimester are recommended to be particularly attentive to social distancing and minimizing contact with others. Women with suspected having been exposed to COVID-19 should be triaged quickly, given a mask to wear, and transferred to a single occupancy room as quickly as possible. Testing should be performed as per local guidelines and recommendation according to her country. Antepartum care also expectant management at home may be appropriate for many women, and some advise it with certain precautions. For women requiring admission, please remember that droplet contact infection precautions should be adequate. Healthcare providers should consider delaying routine antepartum care appointments for women who have or are being tested COVID positive. Self-quarantine as per local protocol is appropriate. And please look to this picture. This is the protection from droplet infection, wearing gown, mask, goggles, face shield or gloves, all very important. You should take all protective measures to prevent transmission of infection. What about the use of N95 respirator? This is only required for aerosol generating procedures, example during intubation, during operations, during intubation in ICU, and ventilation. The duration and the discontinuation of the precaution should be determined in accordance with public health agency guidelines. This picture shown in 95. For maternal surveillance, close monitoring or initiation of obstetrical early warning systems appropriate. Initiation of antepartum corticosteroid to enhance lung maturity if you're expecting preterm labor is wise to do it. Antepartum fetal surveillance of confirmed cases of COVID-19 should occur monthly and include fetal ultrasound assessment for growth and anatomy and the amount of amniotic fluid. Timing of delivery. When should the pregnant lady be delivered? It depends on disease severity, existing comorbidities like preeclampsia, cardiac disease. Also depend on obstetric history, gestational age, fetal condition. Elective cesarean delivery could be delayed if possible until a woman is no longer considered infectious. So long as there is no harm for the pregnant lady from this delay, you can delay to do cesarean while the infection resolves. In mild and stable cases, responding to treatment and in absence of fetal compromise, pregnancy may continue till reaching term. Under close surveillance, please remember to do monitoring for the vital signs like temperature, like blood pressure, respiratory rate, heart rate, oxygen saturation, by pulse oximetry, dynamic assessment of electrolytes, blood pH, arterial blood gases, acid-base status, electrolytes, and the fluid balance. All of these are important. In critical cases, you may need to take a decision about termination of pregnancy, especially if before medical legal viability, and you should counsel the patient or her family about this and respect the ethical points. What about the intrapartum care? Remember again and again, droplet contact precautions should be used, including wearing surgical mask, eye protection, gown, and gloves. And remember also to use N95 respirators should be reserved for aerosol generating procedures as in intubation and in ICU during ventilation. Unnecessary health care personnel in the room should be minimized. Ask everybody in the room who is not in need, not present in the operative theater or in ICU, because we don't want to transmit infection. So minimize the personnel inside the operative theater. It is advisable to limit the presence of symptomatic family in the delivery suite, and visitation should be permitted in accordance to infection control measures. Antepartum fetal monitoring is important because there is reports about fetal distress during labor, so I need electronic fetal monitoring during labor. Epidural analgesia is better if not contraindicated for other reasons, and it is better than general anesthesia because general anesthesia may be associated with risk of spreading infection. Cesarean delivery should be reserved for obstetrical indication. There is no data indicate that the second stage of labor generates aerosols, and as such, droplet contact precautions are sufficient for vaginal delivery. However, if you are doing intubation or intubation is needed for general anesthesia, aerosol generating procedure, the surgical team should wear N95 respirator for cesarean delivery in case there is need to convert from neuroaxial to general anesthesia. There is no evidence to avoid delayed cord clamping or to encourage early cleansing of the infant. Routine practices such as skin-to-skin contact with the mother, wearing a mask, and after having washed hands with water and soap and cleaned by alcohol 70%, and the delayed cord clamping should continue as usual. An individual decision should be made regarding shortening of the second stage of labor with elective instrumental births like ventouse or using a vacuum in symptomatic woman who is becoming exhausted or hypoxic. So you may need in certain patient complaining of hypoxia or became exhausted because of the COVID-19 positive respiratory distress. So you may help by shortening the second stage using vacuum. Appropriate patient transfer planning should be made so to minimize exposure of other patient and the hospital staff member. So take all measures for infection control. Hospital birth is better or home delivery. Hospital birth is preferred in COVID positive pregnant rates. Why? Because we need to ensure the presence of appropriate personal protective equipment, and also we need to electronic fetal monitoring for the baby, so it will be suitable to be delivered in the hospital more than home delivery. Regardless of gestational age at which pregnant woman was infected, the newborn should be tested for COVID-19 at birth. Please remember to take nasopharyngeal swab and the umbilical swab of COVID-19 and do PCR for the baby immediately. What about postpartum and the newborn care? Management in postpartum period should be guided by patient-centered discussion about the available evidence and its limitation. Please remember all infection control measures. We don't recommend universal isolation of the infant from mother. However, depending on the family's values and the availability of resources, they may choose to separate infant from the mother until isolation precautions for the mother can be formally discontinued. So, we encourage the mother to take care about her baby, but washing her hand and wearing mask and take care about all infection control measures. If there is circumstances that interfere with, with control of infection measures, so separation may occur for 2 weeks until the mother becomes non-infectious. Okay, women should wash her hand and wear mask while engaging in infant care. We encourage, as we said, breastfeeding after washing hand and washing the nipple and the breast with soap and water. It should be clean. Also wearing mask during breastfeeding, but if the mother is too ill to breastfeed, should be encouraged to express milk that can be given to the child via clean cup and spoon. What about the management? Pregnant women suspected of COVID-19 should be isolated and investigated. Those diagnosed with infection should be promptly admitted to a negative pressure isolation ward, preferably in designated hospital with adequate facilities and multidisciplinary expertise. As we know, we need obstetrician, we need anesthetist, we need ICU doctor, we need microbiology specialist for infection prevention and control, and also we need lab personnel, doctors and physicians. So we need multidisciplinary team during management. And we should divide our cases into 3 categories: mild, severe, and critical. Mild, symptomatic patient with stable vital signs, severe respiration rate more than 30 per minute, and resting saturation oxygen less than 93%. Critical cases: shock with organ failure, respiratory failure requiring mechanical ventilation, or refractory hypoxemia requiring extracorporeal membrane oxygenation. So please remember these 5 categories in management: supportive therapy, antiviral treatment, antibacterial treatment, corticosteroid, and anticoagulant therapy. Let us start with the supportive one: adequate rest, hydration, nutritional support, water and electrolyte balance should be ensured. Please remember to monitor vital signs and oxygen saturation closely. Depending on severity of the disease, supplementation of oxygen inhalation should be given via high flow nasal cannula. Depending on severity of hypoxemia, you may need intubation and mechanical ventilation, or even extracorporeal membrane oxygenation to maintain oxygenation according to the severity of case. What about this second line of treatment, which is the antiviral treatment? Antiviral treatment has been routinely used to treat COVID-19 infection and also recommended for pregnant patients. Combination therapy with antiproteases like lubnavir and ritonavir has been preferred during drug regimen, as it is known to be relatively safe in pregnancy. What about the dose? The dose is 2 capsules of lubnavir, ritonavir orally together with nebulized alpha interferon, as you see here in picture, inhalation twice a day. Remdesivir, also a nucleotide analog, and the chloroquine and anti-malarial drugs are promising drugs against COVID-19, and they are known to inhibit SARS-CoV-2 virus in vitro. Also, clinical trial on human being is done every day nowadays in many parts of the world and give a good response, as report said. This is one of the paper reported in March 2020, use of hydroxychloroquine and the azithromycin. This research was done in France, Guthrie et al. 2020, they concluded that despite its small sample size, our survey showed that hydroxychloroquine treatment is significantly associated with viral load reduction or disappearance in COVID-19 patients, and its effect is reinforced by azithromycin. In this, Guthrie et al. Gave hydroxychloroquine and azithromycin for 20 cases treated, and they end the research at the 6th day and did nasopharyngeal swab to see the viral load, and they concluded that this combination leads to viral load reduction. Another reported research published in Lancet Respiratory Medicine, 15 of April 2020, trying to search for the evidence base for the use of hydroxychloroquine for treatment in COVID-19. As you see here, Guthrie et al. Has 2 researches, Chen et al. Has 2 researches, and Molina et al. Has 1 research. You can notice that there is no mortality in all researches except one here and another one here. Adverse events, no reported here, 7 the second one, and 4 out of 15, 2 out of 31, and 1 out of 11. They used hydroxychloroquine in a dose 200 milligram every 8 hours, and azithromycin used 500 milligram on day 1, then gave 250 milligram from day 2 to day 5. What is the mechanism of action of chloroquine and the hydroxychloroquine to decrease the viral load? Actually, it depends on the pH. Chloroquine can cause alkalinization of intracellular phagolysosome, which prevent virion fusion and the uncoating. Therefore, viral spread. Okay, this is the RNA virus of COVID-19 attached to the receptor, then enter inside the cell. This is the cell. The virus wanna to be fused with the cell, then uncoating and the release of RNA and the replication. If we stop this and prevent fusion and uncoating, we succeed to stop replication of the virus. This is what hydroxychloroquine is supposed to do. Increase pH or alkalization of the pH of phagolysosome leads to prevention of activity of lysosomal enzymes. Lysosomal enzymes, proteases, are important in activating coronavirus spike proteins for membrane fusion and uncoating. So if we inhibit these enzymes, the virus cannot fuse or do uncoating, and so cannot do replication. Early results from clinical studies conducted in China suggested that chloroquine use might have been associated with reduced fever, increased resolution of the lung lesions on CT, and delayed the disease progression. But still, many studies are needed, and the large studies are needed to confirm these results. What about the safety of using hydroxychloroquine? This is one of the systematic review published in 2009 for the use of hydroxychloroquine in autoimmune disease. They concluded that the hydroxychloroquine is safe for use during pregnancy. However, we can consider hydroxychloroquine as in drug classification of pregnancy as grade D, but we can use it in regard the benefits outweigh the risks. And actually, up to now, there is no proof for any fetal anomalies or stillbirth or miscarriage as a complication from use. So up to now, it is safe to be used during pregnancy, especially if it is given in a small dose and for short duration. On the other side, also, azithromycin is safe and considered grade B classification. It is safe during pregnancy, so they can be given as mentioned by WHO and as recommended by FDA, but in hospitalized patients under observation because chloroquine and hydroxychloroquine may have cardiac toxicity or cardiac myopathy, also may have neurological problem or retinopathy. What about the third group? We finished supportive treatment, antiviral treatment. This is the antibacterial treatment. Antibacterial treatment, because there may be associated secondary bacterial infection, we will do culture and sensitivity test to know the proper antibiotic, but we should start empirical before the result come with ceftriaxone 2 gram intravenous daily until the result of culture explore. Corticosteroid should be given or not. There is controversy about this. Why? Because giving corticosteroid for viral infection may be a cause of delay of relief from virus infection or delay in virus clearance. On the other side, I may need to give corticosteroid to ameliorate lung inflammation and to prevent acute respiratory distress syndrome. So I wanted to start with 1 to 2 milligram per kilogram body weight per day for 3 to 5 days. So it is short course to prevent acute respiratory distress syndrome. Other corticosteroid may be needed for obstetric reason like betamethasone 12 milligram given intramuscular, 2 doses 24 hours apart to enhance lung maturity of the fetus if suspected preterm labor. For suspected cases with preterm labor. Lastly, the giving anticoagulant drugs like heparin and low molecular weight heparin. Is it important to give the pregnant lady heparin or low molecular weight heparin? The answer may be yes. Why? Because one of the pathologists discovered recently for COVID-19 that it may cause microvascular pulmonary thrombosis. So pregnancy itself is hypercoagulable state. So the pregnant lady has carrier risk of being hypercoagulable due to pregnancy, and also if COVID positive, so suspected to microvascular pulmonary thrombosis because COVID-19 increase the coagulability and is a risk factor for thrombosis and thromboembolism. Also, limited mobility of COVID positive cases and the restriction of the mobility and the isolation and decrease its activity may be also another risk factor for thromboembolism, so may be needed to give anticoagulant, especially during the last trimester. This is some references from American College, from recommendation of Royal College, from Lancet, from World Health Organization, and from ACTA journal, so you can read more in this. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.